Hey everyone, how's it going? Let me know if you can hear or see me. All right, Nicole and Jessica. Hey Allison, how's it going? Great. My stream was disconnecting and then reconnecting. Hopefully it'll stay on. And we'll get started here in just a few minutes. Hey Aaron. Whoever wrote me those nice messages yesterday on the sticky board, I do appreciate it. You guys are very nice. I don't know if I'm deserving of all your praise, but I appreciate it. Aaron. Boy, we just got a long week. You guys have a long week with me. I mean, 4 times, my goodness. And I think 8 hours of me is probably 8 hours too many, but what you guys paid for, you're here, so. Friday would be nice. That is true. Likely be here before you know it. Kelly. Maybe May 14th. Is that our last day of classes? Hey, Kaylee. I'm done with you guys, what, on the 26th is my last exam? Yep. Very nice. I don't keep track. I just look to see what my last day of classes is, generally. That's the end of the semester for me. For all practical purposes. Alright, it's 12:30. Make sure my phone's not gonna buzz. Yeah, let's get started here. So, someone did have a question. They're asking about where am I getting my information for COVID vaccines. Oh, don't worry. You have still more time with me during the summer, so don't you worry. Just might not be as concentrated, but anyway, someone was asking about the COVID vaccines, where I'm getting my information. Honestly, and I'm sure maybe you're just trying to find out where I'm getting my testable information from. Very sneaky of you, but actually, if you look on Up to Date, they have a nice article that I'm pulling most of my info from. This is an article specifically just for COVID vaccines. They have more general pages. This one goes into quite a bit of detail. But you can see they go into things like the immunogenicity, efficacy, things like that. And so I'll touch on that when we get to that section a little bit later on, once it's all updated. And, we'll talk about things like when they say like it's 95% efficacious, like what do they mean by that, right? So how can you determine efficacy of something if you don't get the disease, right? Like it's kind of, you can tell if something's efficacious like hypertension because it lowers your blood pressure, but with this, you're trying to prevent something from happening in the first place. We'll kind of get into the nitty gritty of that sort of info later on. So, my understanding though that Pfizer is more efficacious just in terms of like preventing disease, but there might be some more details we'll talk about in terms of like, do the people that get that vaccine, like how sick do they actually get, how fast do they recover, things like that. So we can get into that later on. But anyway, so we were talking about our infectious disease section here. So I want to continue on talking about hepatitis. We have the three main varieties we're going to be talking about today, some of which we may have more things in terms of treatment to use than others, but and we'll see there's some pretty interesting developments in the past couple of years or so, especially for Hep C. Hepatitis A is one of those things that you may run into that's generally self-limiting. It's not going to be something that requires a ton of actual medication for. But certainly due to vaccinations, we see, fewer cases popping up. But even just within Florida, I think within the past, 2 to 3 years, I think we had a outbreak of hepatitis A cases. And again, you can see this being shed in the feces, so a lot of fecal-oral transmission, contaminated water, things like that. Generally speaking, though, if people get it, it's usually self-limited, and then you're conferred immunity after that. So those that have not been vaccinated before, once they get it, then they're fine after that point, assuming they make a full recovery. Most people generally recover about 2 months, but then if they don't within that time frame, then usually within 6, they'll have that recovery there. Oh, I forgot to start recording. It's okay. Hopefully I won't need it. But we'll see here that our goal, though, generally speaking, is try to, reduce any complications if they do occur and try to get back to sort of a normalization of liver function. We'll look at some ways we can do that. And hopefully decrease transmission. That'd be great if you could stop further spread of the disease. But obviously, the vaccines are going to be the best forms of prevention. Here's just an example. I'm not going to get real specific on the brand names for the different vaccines. You should definitely know that a vaccine is available for Hep A. But here we have two. They're Havrix and Vacta, and they are going to be recommended about 12 months of age. I'm also not going to get super specific, and you'll see this when we get into the immunization section later on. I'm not going to get real specific in terms of when you're supposed to get various vaccines. I don't know if Professor Sales gets into the nitty-gritty of that in the PED section. But I look that stuff up too. If it comes up, if you do it every single day, you'll know it, the CDC recommendation for scheduling like the back of your hand, but I don't really need you to know that for my purposes. But, so obviously if you can get the vaccine, then you're going to be good to go from that standpoint. And then other than that, good hand washing and making sure if you're doing things like, changing diapers and then preparing food, like you're washing your hands in between, which seems obvious, but some of these really obvious things may not be so for some people. Now, we do have immunoglobulin, and this is basically taking antibodies from people that are immune. Oh, she did test you on it for PEDS. Yeah, that's, that's okay. I guess it's good to know it at some point. But again, for my thing, I just look it up, but regardless. And we do that a lot too. Usually for kids in the NICU, for a while they'll come up and need their vaccines, and so I'll look that stuff up usually then, just to make sure they're getting everything they're supposed to at that time. But anyway, so we do have immunoglobulin available for Hep A. It's not common that we use it since people mostly kind of recover on their own. Basically, this is immunoglobulin, or antibodies are taken from people who have donated blood that have immunity to it, and then pooling that together so that way you can go give it and then neutralize whatever virus it is in that patient. Generally speaking, this is pretty expensive. It's a foreign blood product, so there's always risk for things like anaphylaxis. Some people don't want to get foreign blood products because of maybe religious concerns. And we generally save it for people at the extremes of age, so like the very old or the very young, and then if they're immune compromised and they wouldn't be able to sort of clear it on their own and fight that infection, then we can help them out by giving them the immune globulin for that. So those are kind of the big things in terms of treatment, right? For Hep B, this is actually a very highly infectious virus here. Another one that we do have vaccines for, but again, you may find some people will, may have never been vaccinated, or this is one of those cases where you can actually see their antibody titers dip over time. And so we'll talk about things like, vaccine durability, later on in the course, but basically you can see that you may not retain immunity forever, right? So things may dip down over time. And again, this is one of those things that could be spread, parenterally, perinatally, sexually, and we'll see here that for some people they can clear it, for others they can't. And so we look at things like their the antigen titers. We look at things like or have they produced the antibodies, things like that, to try to figure out if the patient is going to be able to clear it on their own or not. Generally speaking, if they still have persistent antigen levels past 6 months, then they're probably not going to be able to clear it on their own. In that case there, we may need to consider medication treatment from that standpoint. I'll show you kind of a flow chart and how we can manage that. And here we see the HPV vaccine is really one of the first ones that we had that actually prevented a human cancer, mainly liver cancer. So it's pretty neat. We've had others since then, things like Gardasil for HPV and things like that. We also can find cases where we can have hepatitis B immune globulin that can also be administered too. And again, those would be saved for those patients that are really severe, compromised, things like that. In terms of vaccines, we have a couple here, Ribavirin and Energix. Some of them will actually have both together, so like Twinrix is an example. Again, there's so many different brand names for these, it's just hard to keep a lot of them straight in your mind. So again, you can look this stuff up, right? And this is one of those ones where you do need multiple doses in order to kind of re-challenge the immune system to make sure that you get that durability, that you get that memory developed. So that way, if you do have another exposure, you can go ahead and fight it off there. This is a pretty common one. If you go work in a hospital, for instance, you may get your titers checked, and they may need to give you a booster, for instance. I think I had to have one when I started at Nemours. Got a booster, now my titer levels are looking pretty good, I guess. Presumably still looking good. So our goal here is to get viral suppression, just like we saw with things like HIV, and if we can get them to seroconvert to having loss of the antigen and them developing the actual antibodies, right? So again, having the anti-hepatitis B antigen, right? And this is the envelope antigen, so it's a specific part of the virus they're looking for there, and then lose the actual antigen itself. So that would show that you have the antibodies, but you've cleared the virus. And if we can try to prevent any kind of hepatic complications, so things like cirrhosis and cancer and whatnot there. The patients who generally get treatment for this are going to be ones who have shown either evidence of liver disease from this, some sort of morbidity, or if we see that it's been a period of time where they're not able to clear it on their own. And I'll show you the flow chart here in just a moment here, but basically they're going to undergo the serial monitoring for hepatic function, and then you're also looking for the serological markers for the infection, and then you can make a decision on when to treat there. So here's an example of how you would do it for this type of patient, where basically you're looking again at their the antigen, you're looking for the antibodies. Hopefully they'll produce those on their own, and you'll see here, okay, if they still have the viral, their count above say 20,000. I'm not going to get specific on the numbers. And then you're looking at their liver function test. And if they're above 2 times the upper limit of normal, then you can consider starting treatment. Otherwise, if their liver function is still looking good, but they don't have high viral load, then, or they still have a high viral load, but the liver function looks good, then you don't necessarily need to do anything. You can just keep monitoring it. Just hopefully they'll clear it on their own. Otherwise, if they have evidence of hepatic injury, so like jaundice, some sort of decompensation, or if they start to see the LFTs start to spike up, that can be signs you need to go ahead and start treatment here. So we'll talk about some of the different options, including some things like PEG interferon and things like that we'll get into. So first drug here we'll mention is going to be interferon alpha. So this is kind of interesting because it works as a host cytokine. So it basically is sort of kicking your own immune system into high gear, sort of stimulating it to try to fight off that virus there. And so basically you're going to see a lot of inflammation associated with this. Interferons typically have pretty nasty side effects, all in all, pretty harsh drugs to be on. And so I'll go into a few of those here. And so you're going to see these immunomodulatory sort of effects here. It's going to kick up that inflammation and again try to fight off that HBV virus there. It is a protein, so it has to be injected, and just regular interferon alpha is like a thrice weekly injection. So again, not super fun for the patient there. Since then, it's been supplanted by PEG interferon alpha, which is basically a modification of the interferon, and that one only takes once weekly injections and has a little better efficacy. So, and again, since these are proteins, they're going to be pretty expensive. Not at the current price, but it is quite expensive. Someone says, can you lose antibodies against something? So you got COVID, would you expect the antibodies to stay up, or is there a chance it could decrease and you can get COVID again? I don't know if we know that for COVID specifically, but certainly you can lose the that memory, so to speak, of immunity against a disease, which is why you need things like booster shots and things like that. So for instance, with like, tetanus, we get a booster because we know that we're going to lose some of that, that efficacy of or that immunity over time, and so you can re-challenge it and then get a stronger response that'll stick around. But I think it's probably too new to say whether or not that we're going to see, do we need a booster shot in the future of a COVID vaccine? I don't know. I don't think anyone knows that at this point, but it'd be interesting to see how things develop there. Oh my goodness, I lost my PowerPoint. Here it is. So anyway, yeah, these are interferons, rough drugs here. So a lot of adverse effects. So one thing you can see is risk for infection, which seems kind of odd since you're kind of increasing the patient's immune system, but this is more so for patients who already have like cirrhosis. They're more likely to or if they have a decompensated cirrhosis, they're more likely to get infection. It kind of seems like the immune system's not really being super, it's kind of ramped up, but it's not being as effective for maybe other types of infections it's trying to fight off. So that's something you can see potentially. And you can see actually these flares and sort of decompensations that can be brought about by the drug. So again, these are typically used for the sicker patients, and so sometimes you wonder if the patient would decompensate anyway, or if it's the medication itself. But the big things here you're going to see are the black box warnings for these neuropsychiatric events that can occur here. So if a patient has like a history of depression, you can see worsen depression. You can see risk for like suicide. Patients typically are usually I see a lot of times they get into a really bad mood and they're kind of like cranky and they get kind of angry. And anyone wife who was talking about her husband who's receiving he had hep C and was receiving interferon for that. And she would always say, like, oh, yeah, I always know when he's getting it because he's always such a jerk when it happens, right? Not a fault of the patient, it's just the medication that seems to be doing that for whatever reason. Other things you can see, too, include some autoimmune disorders, which kind of makes sense if you're ramping up the immune system there. Ischemic conditions, infectious disorders, again, not necessarily linked to the mechanism of the drug, just stuff that they've seen that can be potentially life-threatening. And then there's also risk for things like anaphylaxis because it, again, is a protein. Now, you're going to get this kind of flu-like symptoms anyway because you're ramping up that immune system, so it's not uncommon for patients to get kind of like low-grade fever, myalgia, things like that related to it. Yeah, just not a great drug, so if you can avoid using it, it's always good. Here again, you can see the depression, suicidal ideation kind of linked to that, and there is some risk for some blood dyscrasias as a result of kind of, again, ramping up that immune system. So don't really know the full optimal time to treat here, but it could be up to like 24 months, which is, again, why it's so expensive. And again, it's 2 years of treatment. It can be really difficult to do that, especially if patients are, have kind of unstable social situations, things like that. So compliance can be a challenge. So other ones we could use to try to kind of prevent replication of the virus itself could be things like lamivudine, which we've seen previously for treatment for HIV. Does have some activity against HPV, but is not going to be considered sort of a first line. But you can see here that patients can be given this sort of indefinitely to keep the virus from sort of replicating as strongly as it normally would. But you can see things like resistance that can pop up. You can see things like relapses of disease where they're doing well for a while, all of a sudden it starts to kind of flare back up. Be an issue. Adefovir is another one called hepsara. So kind of the brand name kind of clues you into the indication here. Has a similar mechanism to lamivudine, being sort of like a false nucleotide, so kind of preventing replication of the DNA there. It may be used in some cases where if you have like lamivudine resistant HPV, then you could use something like this. This one you do want to watch renal function since it can cause nephrotoxicity, so you'd monitor their serum creatinine along with the liver function test you're going to be doing anyway for these patients here. Other ones you could use potentially include things like tenofovir, which I know we talked about before or yesterday. This one is starting to be considered sort of first line nowadays, and we're seeing lesser resistance rates over time, so that's going to be a good option for a lot of patients here. And then things like telbivudine and entecavir could be used in cases, again, for more kind of resistant strains there. So again, you kind of have different options. I think tenofovir nowadays, though, is becoming kind of preferred in a lot of cases for sort of chronic sort of suppression of that virus from replicating there. So kind of interesting. So switching gear, we next have Hep C, and so this one used to not really have definitive treatment, right? So some patients, if they're exposed to Hep C, may have clearance of it naturally, but a lot of people will just continue to have chronic disease. And again, beginning in 2013, so really not that long ago in the grand scheme of things, this was just a chronic condition. You were never going to get rid of it. You just had to be on sort of chronic treatment with things like interferon. There's another drug I'll talk about called Ribavirin, which is also a pretty harsh sort of drug, and it was pretty miserable because, again, you're just like either are on these medications or you have to worry about things like getting a liver transplant. But like I said, as in 2013, we now have sort of revolutionized the treatment for it, and people can be cured within just a few months, as we'll see here in just a little bit. So I'll talk about those new drugs and kind of how they've sort of changed things around, which is pretty neat. But you're going to see a lot of acute cases do go into chronic infections. Basically, your own immune system's not really sufficient to clear it on its own, and that the virus just will have kind of rapid diversification there. Yeah, so someone's saying, so overall tenofovir would be first line treatment for Hep B. Yeah, so that's becoming sort of the first line. But, if I said, which I'm trying to think of different questions I could ask, but I could say, which one of these would be appropriate for Hep B? I could put something like a protease inhibitor, like, lopinavir and, different things like that. And you'd be able to pick out tenofovir as being a good option. I don't know that I would ask you necessarily to put up head to head like lamivudine versus tenofovir and say, which one should you use? But, I don't know if I'm going to be that specific about it. More so, be able to recognize the drugs, know what they're being used for, if that's appropriate or not, things like that, I think are good to know. So nice to give you like example questions and everything. Jeez, I used to not be so nice. I used to be a lot meaner, but then my evals are all bad. So then I'm just kidding. Oops, I'm getting a little sized here. So anyway, so let's talk about Hep C and the ways we can treat that. As I mentioned, it used to be that we just had the chronic condition. You just try to suppress it as much as you can. However, nowadays we can eradicate the infections. The goal is to have a virologic cure. And so basically we'll treat them with one of these new courses here, and then hopefully we're going to find non-detectable HCV levels about 12 weeks after the end of treatment there, and hopefully prevent any need for things like liver transplants, end-stage liver disease, things like that. And you're going to see here, as opposed to Hep B, where you can sort of sit back and wait and see what happens, kind of a watch and wait sort of approach. Here, we're going to recommend treatment for everyone. And then we will be doing some baseline therapy at first. We're going to see there's different sort of subtypes of Hep C. You got to figure out which ones you're dealing with at first, and then determine if there's any resistance. And then you can go ahead and start treatment at that point, and determine, okay, how well they're going to respond to this. So, as I mentioned before, we used to utilize things like interferon, another drug later on I'll talk about, Ribavirin, which is, again, very harsh in terms of its side effects. Again, they're injectables. They're all very expensive. Nowadays, we have all oral regimens, which is fantastic because, again, that really helps out with compliance. And they're usually the treatment courses between 12 and 24 weeks. So again, within, 3 to 6 months, someone could be cured of Hep C, which is before it was like a lifetime, sentence basically, which is pretty wild. So there's GT 1 through 6, which are sort of the subtypes of hepatitis C. We'll find that 1A and 1B tend to be more common in the US. Some of these drugs are going to have more activity against one subtype or another. Again, I'm not going to get real specific in terms of which subtypes which drugs go against. There's so many other drugs you need to know anyway for this. I'd rather you at least be able to identify the drugs, what they're used for, interactions, things like that, as opposed to get into that sort of nitty-gritty detail, because if you need to, you can look it up, right? Anyway, so the new class that we have here for these drugs are called the direct-acting antivirals, or the DAA. You may see it abbreviated occasionally here. And so basically, you're going to find that, again, when you're producing a new virus, it's just going to translate all of that RNA over into proteins. And it's sort of going to be in this big, long string of amino acids that has to be chopped up into the more functional, mature components, right? And we'll see here that we're going to have abilities to either affect that maturation process, or we can do things like inhibiting the proteins once they're actually made, and especially the proteins are going to be responsible for making the viral RNA and replicating that. So I'll get into the different drugs here, and they have some pretty difficult to pronounce names. They just are a string of, what's the word I'm even thinking of? String of syllables that just don't go very well together for me. So if I get a little bit of mush mouth, you'll have to, I apologize. Anyway, the first one we have here is called decladisvir or Declenza. This is effective against GT1 and 3. Again, I'm not going to ask you on a test. Okay, patient comes back and has GT2. Which drug are you going to use? I'm not going to get that specific, okay? But what this does is it basically prevents that viral replication by binding to that NS5A protein. So you can look back here, you can see where this protein is at, how the inhibitor will come in and prevent replication of the viral RNA itself. Basically, it comes in and sort of distorts the structure of the protein and it impairs its ability to work to make new RNA there. So again, you prevent the HCV from replicating, and this hopefully can kind of choke it out from that standpoint. Again, other big benefits here is that there's not really a bunch of dose adjustments you're going to need for the majority of these drugs in terms like renal or hepatic insufficiency, which is fantastic. And if you look at the side effects, much better than you would see for things like interferon. So here you can find headache, fatigue, nausea, diarrhea, much better than having to worry about things like neuropsychiatric events as a black box warning, things like that. Downside is though that they are going to be pretty expensive here. So $20,000 just for this one drug for a month, right? So you're thinking, okay, well, the patient needs to get 3 to 6 months of treatment, depending on some factors that we'll talk about. It's pretty expensive. Although on the flip side, if you're thinking about, a lifetime of treatment for Hep C, need for liver transplant, it ultimately comes out that this is much cheaper in the long term. And so generally speaking, insurance companies, if the patient has insurance, is more likely to pay for this than wanting to pay for, that transplant down the road. So, it makes kind of good sense from that standpoint. However, again, compliance has to be ensured. Like, it's really, really important if you're going to be sending these patients out, that they need to really be compliant, take every single pill, not only because it's expensive, but also because they want to make sure they don't get resistance. Because if you lose efficacy to some of these drugs, you may not have, again, a lot of options available to you. And I'll show you some of the different kind of treatment algorithms, well, not algorithms, but different treatment options based on things like, whether or not they have resistance, whether or not they have different subtypes, things like that. To kind of give you some clues here. This next one is a combo drug of Ribavirin and sofosbuvir. Kind of difficult syllables to string together, otherwise known as Harvoni, or Harvani, whichever. And this one's going to be working against GT1, 4, 5, and 6. And so basically the combo, again, is going to get some synergy here because the Ribavirin is going to be inhibiting that NS5A to block the replication, and then the sofosbuvir is actually sort of a nucleotide prodrug. Basically, it's going to end up being converted over and then is going to inhibit the NS5B RNA polymerase, and it does that by acting as that chain terminator. So it's very similar to what we saw with our NRTIs yesterday for HIV. So again, working to prevent further elongation of the viral RNA, and then the Ribavirin is blocking the protein from actually running the machine and churning out that RNA, so kind of getting some synergy there. You can't see sofosbuvir by itself, which can be used for different subtypes, and that has again very expensive, about $27,000 per month, $30,000 per month for the whole thing. Again, I'm probably not going to ask you cost on the test, but I just wanted to impress upon you that these are very expensive things, but again, worth it in the long run. Again, benefits: no organ dose adjustment needed. Very nice side effect profile. So again, this is life-changing for a lot of people that were, had chronic Hep C for a really long time there, which is great. Next, we have semepervir, or Licio. This is going to be inhibiting the NS3/4A protease. So this is going to be the enzyme that's responsible for, once you've translated that viral RNA into proteins that would normally chop it up into functional mature proteins, this prevents that from happening there. So if you can prevent that from happening, then you can't make any of the proteins that are normally needed to churn out new virus, which is, again, a different mechanism. Brian's asking, are these covered by insurance, or is it $30,000 out of pocket? It could be for some patients, but again, if you're thinking about it from like the insurance company standpoint, you're trying to minimize your cost, obviously, so you can maximize your profits. And so if the question comes down to, should I pay for this drug that costs $30,000 per month for 3 months or maybe 6 months, how does that stack up to the lifetime that patient's going to have Hep C, having to go in for hospital, if they decompensate, they have hospitalizations, if they need transplant, that's again going to be a whole host of like immunocompromising drugs they're going to be on after that. So ultimately much cheaper to pay for that $30,000 a month for 3 months as opposed to going through all of that. So generally speaking, you would find insurance, it would behoove them to pay for this sort of thing here, and hopefully make it relatively relatively affordable to your patient there. Anyway, so looking at this, so this one is not used by itself. Generally speaking, it's going to be used in combo with something else, like sofosbuvir or maybe like interferon and ribavirin therapy. Sorry, my eyes twitching out. I feel like I'm got into it. Stuff just makes me so emotional, you know. Next we have Onbatavir, which is another NS5A inhibitor, and this is again given in combination with either paratepravir, which is an NS34A inhibitor. So again, getting the kind of dual mechanisms there, or actually in some cases you'll find, or in this case here with the paratepravir, you're giving ritonavir as well, and that is actually used to boost levels of the paratepravir. So utilizing that 3A4 inhibitor action of the drug to get better activity here, and so that's a combo of the three drugs called Tecnivi, or you may see it used with or without Disabuvir, which is again going to be another combo medication you can find there as well. So a lot of different combinations you can run into. The last drug I want to talk about here is this Ribavirin, which is an older drug. It's been around for a while, and it's another injectable that has been used for Hep C for a long time. This one we don't really know the full mechanism here. Some people think that it leads to this RNA mutation rate that is high enough that causes an error catastrophe, which sounds like most of my life, generally speaking, but basically causes so many errors in the RNA that it just says this is no good, we're going to have to toss it. It also has some immunostimulatory actions as well, similar to the interferon. And back in the day, we'd have to use basically this and interferon, and that was all we had to treat these patients here. If you look at the adverse drug reactions, again, pretty rough in terms of things like suicidal ideation and depression. You can see things like dyspnea, especially on administration of the drug, and things like anemia can happen between like 10 and 13%. So that's pretty relatively common. 1 in 10 patients are going to be developing this. Can happen pretty early on in terms of treatment there. Not great, right? Also, this one's kind of interesting because it's a pregnancy category X, meaning no go for pregnant patients, no reason for them to be on this, at least during that 9 months or 10 months of pregnancy here. But they actually recommend that female patients or anyone with childbearing potential uses 2 forms of birth control for up to 6 months after you've used the last dose of ribavirin, because it can still stick around in the system long enough to still have some effect on the fetus. So which is kind of interesting from a standpoint. If you have a patient who wants to become pregnant, they have to really consider when the last time they got this drug was. So how are we going to be using these? So basically, ribavirin is going to be used for patients that have really difficult to treat disease. So if they've had like prior treatment experience, or if they have underlying cirrhosis, that's when you're going to be adding on ribavirin, right? So I could ask you, a question about that, being like, okay, when would you want to use ribavirin? What type of patient would you want to use it for? Those would be the typical people you want to do for that. Like I mentioned before, we used to use PEG interferon pretty commonly. It's kind of standard treatment for these patients, but that's gone down pretty significantly since the direct-acting antivirals were developed there. But if you do have patients who have cirrhosis, so they have like long-standing Hep C, they can be pretty difficult to get a good sustained virologic cure on, and you'll see that some of them may have to have some adjustment here. So for example, the Onbatavir, paratepravir, and ritonavir combo, but most of the ones we saw before didn't require any adjustments, which is again a benefit to them. But if patients do have treatment experience, so they've been on things before, you can consider doing things like resistance testing to see what it's going to respond to, but typically they require longer treatment. So if they've had previous treatment with things like ribavirin and interferon, and you're switching them over to a direct-acting antiviral, for them, they may require up to that 6-month time frame. So instead of 3, you go 6 months, and then adding on the ribavirin as well to get some better synergy there. Now, for people with like acute exposures, about half of them do clear the HCV sort of spontaneously after 6 months. If you want, you can defer therapy until then, but some people may opt to want to treat early. So, again, that may be something where insurance could come in and say, hey, well, let's wait 6 months before we'll approve this. I'm not really sure, since I don't really deal with the insurance side of things too often. Honestly, we don't see a lot of Hep C in pediatrics anyway, but not to say that it doesn't happen, but it's rare. But yeah, so in those cases, you could potentially defer. And then as I mentioned, compliance, extremely important. So any delay can lead to that resistance and failure for the drugs. And once you lose those, you may not have a lot of options. So make sure that patients can actually receive their medication every single month. Make sure they know how important it is to take it. Again, try to do everything you can to ensure they're going to be compliant. Okay. So this is a table which is not very pretty, but kind of gives you an idea of what you could do based off of whether or not the patient has cirrhosis and then what subtype of HCV that they have. And again, I'm not putting this up there just to make you memorize all of these, because that would be terrible. But just to show you the different options you have here and notice sort of the trends. So for instance, here with no cirrhosis, a lot of these you're going to be treating for 12 weeks. So just the 3 months and then they're done, versus if they have cirrhosis, you're adding on the ribavirin and you're going for that 24 weeks, right? So that's kind of the big differences there. For some, like the 3 subtype, you can see here they even have interferon listed as an option there. So obviously those are the more difficult to treat patients. You're going to be adding on drugs with more side effects. So again, that should be something that's considered as well. So, right. Anyway, so that's it for this section. Do you all have any questions? Someone said, so is ribavirin still used with interferon today, or is it now used with a direct-acting antiviral? So ribavirin, nowadays, typically it's the direct-acting antivirals, and then if they have treatment resistance or they have cirrhosis, and you're adding on the ribavirin to that. So that's generally speaking what we're going to be doing there. Someone said, what's the difference between interferon and peg interferon? One comes from the blood of a Pegasus. I'm just kidding. That would be pretty cool, though. It's more Harry Potter territory. But basically, it's a pegylated form of the drug. It's basically an alteration of the drug to help out with things like half-life and things like that. So that's what the pegylation is. It stands for peg interferon. That pegylation is shortened to peg interferon, basically, from that standpoint. Let's see. So someone's saying for HCV, if you wait 6 months before starting meds, would it be harder to treat? Not necessarily, right? So if anything, you might. So again, if you're waiting that 6 months, you're not treating them with anything. So there's no reason for the bug to become more resistant, if that makes sense, right? Because you're not really putting any selective pressure on them to develop resistance. So the only thing you'd really be worried about is the hepatic complications. So you'd probably be seeing them more than just that 6 month period. You'd probably be seeing them maybe every couple of months to every month in order to do repeat LFT checks. And if they start to increase and they're showing that they're not going to clear the HCV, then you may want to decide to treat earlier, right? So that's really the only thing you're really risking at that point. I don't know that you're necessarily going to find that it's harder to treat at that point. Someone said, why would you wait 6 months before adding ribavirin? You wouldn't wait 6 months before adding ribavirin. That was more just in general in terms of treatment. Again, if you have someone with the exposure and they do have the HCV, it's like a brand new diagnosis. You could not treat with anything during that first 6 months and watch and wait if you wanted to. Some people will opt to go ahead and just treat right away. In those cases, those patients probably wouldn't need ribavirin. This is more so for patients who maybe have previous treatment courses that are being switched over to the direct-acting antivirals. Maybe they have resistant disease, maybe they have cirrhosis. That's when you're adding on the ribavirin at that point. Hopefully that makes sense. Any other questions before we move on? So I got the geriatric section up next, and then I posted the ER section there. I'm going to do immunizations after ER. And then based off how much time I have left, I'm going to maybe have to trim some of the toxicology lecture. I have some extra sort of ancillary stuff because I don't really get a chance to talk to you guys about tox elsewhere. I try to build it into this class. So I have some things about like, fish envenomations or marine envenomations. I might have to cut some of that if it's if I don't really have time, since it's not something you see quite as common. Although we do live in Florida where all kinds of creepy crawlies do exist. Kind of feel like we're like the Australia of the US a little bit. I'm sure some other states would probably want to argue that, but anyway. So let's go to our geriatrics lecture here. So this is a little bit of a rehash of kind of what we did back in pharmacodynamics back in the day. But the benefit here is that we now have more context for using these medications, right? Before you didn't know any drugs at all, practically, but now we have a lot of drug knowledge. And sort of all along, we've been talking about geriatric patients anyway, because they do make up a big chunk of our patient populations. For most of you, wherever you go to work, you'll probably be dealing with a lot of geri patients. And so you want to be able to, we've already talked about things like, what do we look for? What do we watch out for? Things like that, and with our medications here. But regardless, we're having an older population. We're having a lot of those baby boomers are now getting into the geriatric age range. If a lot have already done that, I find it kind of interesting watching like some videos about the when the baby boomers start to die off, all of the transition of wealth is going to be like one of the biggest transitions in the history of economics, which is kind of interesting. But regardless, they're getting older. We're going to have to treat them. And so I like to focus on the assessment portion here because that kind of gives you a lot of clues in terms of like how well their medications are already on are working. Do we need to add on more meds? Can we try to trim meds? What can we do for these patients here? Because again, it can become a pretty big quagmire to try to get through in terms of getting optimal medication management for these patients, because they're going to have a lot of polypharmacy, which I'll touch on a little bit later, a lot of medications. And I remember having a very distinct formative memory in pharmacy school where we volunteered to do a brown bag event. For those of you who don't know what a brown bag event is, it's basically where a bunch of us pharmacy students and a couple of pharmacists went to a nursing home, and all the patients come out, and honestly, it's more of like a social thing for them, just because they have young people to talk to. But they bring out their brown bag that has all of their prescription medications in it. Bring it out to us, and we go through them to see, like, is stuff in date? Do they actually still take these medications? What are they taking them for? Are they having side effects? And we can, try to get rid of stuff they don't need anymore. Try to, especially if stuff has been like out of date since the 80s, like they probably don't need to keep it around because that can, provide, chances for errors if they grab the wrong bottle or something, give them a list of questions to go to ask their providers. Tupperware too would be another popular one. But so anyway, so that was a very formative thing because, you'd have stuff that's just like wild how many medications they're on, how they like to hoard medications because, again, they're very financially minded. A lot of people grew up at points where they didn't have a lot of money, so they had that mindset where they like to preserve everything. And so they hold on to stuff that's out of date, that's been, they haven't been on in 10 years and whatnot. And that can be dangerous, right? But anyway, so I'd like to focus on some of the assessments here, not only looking at things like I'm sure, especially you guys that worked with on EMS, having to deal with patients bringing their medications with them and stuff is pretty wild, I'm sure. But anyway, so I like to focus not just on their, the quantity of life we're giving these patients here, but also on the quality of life they have, looking at things like their functional status, like what are they able to do, what are they not able to do. Maybe their medications are affecting some of that, both in good and bad ways, as we're going to be seeing here. And again, it's good to have interdisciplinary care here, right? Because of the fact that when I'm looking at a patient's medication list, is going to be very different than if you're looking at a patient's list. Very different if a respiratory therapist is looking at their list. OT, PT, dietary. We're all looking at the patient from different angles, and in order to get that more sort of whole view, we need to work together, which is something that we have always kind of strive for here. And it's actually in the accreditation stuff for PA schools too, which we have to try to do. But anyway, so when we're talking about things like their activities of daily living, like what can they do, what can they not do anymore, right? So can they get out and go gardening like they used to? Can they, do even really basic things like get up and feed themselves? Can they wash themselves? Can they go to the bathroom by themselves? A lot of times you're going to find that when they are unable to maintain continence, that's frequently a big push for people to get moved into assisted living facilities and things like that, which again, I typically see people like to deteriorate when they go into those sort of environments. So what can they do and what can we try to do to help get them more functional if at all possible? Because again, some of the medications you may be thinking are helping them when in actuality, the side effects may be such that they're limiting some of the stuff that they can do. And so that's why it's good to look for things like, are we doubling up on medications? Are they self-medicating? Are they taking stuff from other people? You have to ask all these sorts of questions here. Now, nutrition is really important for these patients. You will frequently find that, again, it seems kind of tangential to the medications, but it does have a big effect here. For these patients may have like limited dentition, or if they have things like, dysphagia, if they have different disease states like depression, things like that may make them not want to eat, right? Or they may be unable to eat. And so you have to look at things like, are they getting enough dietary intake to maintain their weight? Are they are they having food interactions that are happening here? Are there, maybe they're so constipated that they feel their abdomen so full they don't want to eat ever. Maybe it's due to the medications they're taking. We're kind of gathering all these different ideas here and looking to see how it's affecting their nutrition. Not only that, but they may have lack of access to things like being able to prepare their own meals or financial resources and things like that. So a lot of things can affect this for sure. It's good to get an idea for what their normal dietary intake is kind of like. So as an example, when I was talking about working in that Coumadin clinic yesterday, I think I was talking about that patient who was on warfarin. A lot of those patients out in Palaca, like they grow their own food. Like my grandparents did the same thing. And so we had people that would have, like, they grow their own collard greens. They would do spinach and kale and all kinds of stuff. Well, all that has like a ton of vitamin K. So it had a huge effect in terms of their INR, and we had to make sure they were getting at least consistent levels of vitamin K so we could match the warfarin dose to get to an appropriate INR for those patients there. So that's just one example. Do they grow their own food? Do they, where are they getting their, what types of food and drinks, what kind of quality of those are they getting, things like that. Kyle saying, really weird to do oral care on patients in the nursing home when they only had 3 teeth, right? So it's like, those are precious. Like, you only got the 3 left, so you want to take really good care of them, right? But I also like to think about things like, how much fluid intake are they getting? Because they will typically find these patients can get dehydrated, and that will have a very dramatic effect on renal function, which can precipitate a lot of these admissions to the hospital because they get dehydrated, drug levels get all out of whack, usually high, and that can lead to issues, right? I've had a patient with an inadvertent theophylline overdose because they got dehydrated, kidney function went down, theophylline levels went sky high, and she ended up dying from seizures, basically, during that. So it's very, very unfortunate. But anyway, ask about things like vitamins and supplements because those could be having interactions as well. So for instance, I might have told this story before, but I had a patient who came into the ER that was coming in for stroke-like symptoms. And they had a history of being on warfarin for AFib, but they were also, I think their family member was talking about them worrying about their memory, and so they were taking ginkgo biloba for memory, right, as a dietary supplement, and that ends up can cause some bleeding propensity. So you add that on top of the warfarin, and sure enough, this lady had a massive brain bleed, ended up dying from that, right? I'd say that ginkgo was the thing that, was the straw that broke the camel back, but it certainly wasn't helping, right? So but these are still questions you have to ask. And again, you may not know what every single supplement can do, but you can at least look it up. You can Google stuff, right, and figure out if it's going to be causing any problems potentially. But, in terms of like food interactions with their medications, think about things like if they have Parkinson's. I remember I was talking to a patient one time who had Parkinson's, and they were really kind of lamenting the fact that they have to take their Cinemet in the morning, or levodopa, carbidopa, and they couldn't have their eggs anymore because of the protein interaction there, that the Cinemet was getting basically crowded out by the proteins in the eggs, and they couldn't get absorbed as well. So he was like, man, I really love my fried eggs in the morning, fried eggs and bacon. Couldn't have anymore, or if he did, he'd have to like push them out by several hours. So little things like that can be important. And finding out if they're taking, a big old full glass of milk with their fluoroquinolones, or if they're taking, their bisphosphonates with, a bunch of orange juice or milk or something like that can cause poor bioavailability. So these are all things we can ask about. And again, now we have context for this stuff. Now we know why we're asking these questions because we've run across so many examples, some of which I just mentioned here, right? In terms of alcohol intake, it's always a good idea to, and I know we've kind of brought this up in various grand rounds and whatnot, but ask questions like, okay, well, how many drinks of beer do you have a night? Some people may say, oh, I only have 2 beers, but if they're gigantic, 24 ounce, or it's a 40 or something like that. I think 40s in Florida, but say that you're in Georgia or something, they have a 40, like that could be 1 beer to them, and that's obviously not really, in the spirit of the question that you're asking there. Not everyone else, measures out their wine to the exact, 6 or 8 ounces or whatever the normal glass size is. So ask questions like that. And again, even when you're asking about things like beer, especially with the push for a lot of, microbrews and things like that, you're going from, 4.5%, Bud Light or something like that, all the way up to 9%, really high gravity beers and things like that make a difference, right? Those beers are not equivalent when you say I have 1 beer, right? Again, ask about things like, money and being able to buy food and whatnot. Some of these patients have to make decisions between getting their medications and being able to eat, for instance. Are they self-medicating with over-the-counter medications? It could be interacting with their, it could be interacting with their other prescription stuff. If you don't ask about it, they may not tell you, right? So I always mention the Goodies powders and the BC powders that are powdered aspirin, and a lot of older patients don't know that that's aspirin, right? Even though you can read the labels, but it's pretty small on the back. You just know, oh, this is my headache powder. So for instance, I had one patient, I know I've told this story before, but this is Dr. Whittell's anecdotes day apparently, but one patient who every time he had chest pain, someone told him to take a Goodies powder. right? Not realizing that it was aspirin. So he's having chest pain a couple of times that day, and I'd taken a bunch of doses of that. And then EMS comes in and went to call 911 because the chest pain wasn't going away. EMS comes in, they go, "Oh, have you had any aspirin today?" And he goes, "Nope." And so they give him another dose of aspirin, and then they might not have told him, or he might not have gotten the news. But then he comes into the ER. The doc asks him, "Oh, have you had any aspirin today?" He says no. Gets another dose of aspirin. All of a sudden, now we have the guy's having a heart attack. In addition to now he's got a mild aspirin overdose that's happening here. So he's like tachypnic and getting hyperthermic. Not great, right? Now you have just added on another problem there because of the fact that the patient just didn't know that was actually in the medications that he was taking. Someone's asking, does ginkgo actually improve memory? I don't know off the top of my head. I've not done a real deep dive into that. There's probably some evidence that says it might help, and probably some evidence that says that it does not help, if I had to guess. But it's really tough in a lot of these cases of dealing with dietary supplements because the studies are really hard to do. It's difficult to do like good randomized controlled trials. So it's a challenge, right? So I don't know off the top of my head, but I'm sure there's some good databases out there you can go look to see if there's some info that might be applicable to your patients there. Again, I'm not one that says don't use any herbal supplements. They're all crap. They don't work. Some of them actually do stuff. And some, like I mentioned before, that one actually did contribute to that lady dying because of the bleeding propensity it can cause there. So again, they are not no joke, right? And if used inappropriately. Anyway, so other things you can check out to see, like, okay, what's their ability? Can they even physically go out to shop? Can they cook food for themselves? Can they feed themselves, etc., right? Lab assessments. This is another really important thing that we're going to be focusing on. Certainly, your CMPs, complete metabolic panels. I always love asking students, like, what do you want to order for this person? And everyone says a CMP. And we're like, well, why? And you're like, because it has everything, right? It seems like kind of the shotgun approach to take, but you don't always need that if it's not necessary. But generally speaking, if we were going to order one, some of the things we can kind of think about for these elderly patients here, kidney function is a must to assess. Again, these things will decline over time. We just know it's going to happen, and it's important to reassess their medications they're taking to make sure that the dosing is matching up what their current renal function is, because it's very common that you'll have someone that either doesn't have their labs checked for like maybe years at a time, and they're on that same dose of medication, which is now totally inappropriate, right? And they could be having side effects from it they don't even realize is related because they've been on the same dose this whole time. So why would it be related to the medication? There hasn't been a change. Well, there was, but it was with the kidneys, and they couldn't tell. Be looking at things like their fasting glucose, A1C, check on things like, if they have diabetes, how effective are they being? Again, it's always funny when patients try to trick you a little bit that are non-compliant because, they'll get their labs done, their fasting labs, and their fasting plasma glucose will look great because they decide to take their meds that morning, but then their A1C is still like sky high. And so it's like, okay, well, yeah, your fasting look good today, but also what's it normally like? Because your A1C is not telling the same story here, right? Certainly lipids we're going to be looking at, CBCs, we can be looking for things like anemias and whatnot that could be happening, again, looking at the proteins, look at their blood counts can kind of give you some clues in terms of like, not only like nutrition, but are they getting enough like, things like minerals and vitamins, things like that can be contributing to anemias and whatnot. But, and certainly UAs can be somewhat useful. I don't really get into that too much, but certainly they can also give you some clues there as well. But ultimately, what you're going to find is these medications is that as patients get more and more disease states sort of added on, they're going to be on more and more medications, right? So they have COPD, they have seasonal allergies, they have hypertension, hyperlipidemia, CHF, like the list can get out of control pretty quickly there. And so polypharmacy is generally the rule. And again, also think about the fact they may not just be seeing you as their provider, but they may be seeing a whole host of specialists, or you might be one of the specialists they're seeing. And it's sort of an unwritten rule that you don't mess with other people's work. So if someone is on a medication that that was prescribed by someone else, a lot of providers are very hesitant to do anything with that, to change anything, because that's a professional courtesy, right? Like I wouldn't want you coming in and messing up my work and vice versa. But we can find that can lead to some problems here, especially when you have a lot of these medications that could be sort of either antagonistic to one another, they may be doing the same thing as one another. So it can be really challenging, right? And again, as evidence-based guidelines come out, we may find that, okay, now we need to add on another drug, right? Patients who had a previous MI didn't always have to be on a beta blocker, but now they do because of the guidelines. We know the evidence now shows that helps them live longer, for instance. And again, just as this example, a patient with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, COPD, they may be like on 12 different medications. They're taking like 5 different times per day, right? I can barely take a multivitamin every single day, and I have pretty, I guess that's probably debatable, but pretty decent mental faculties. Give this to an elderly patient and may have a really big challenge being able to stay compliant. And again, sometimes this is no fault of their own other than just the fact they have a complicated regimen. And oftentimes when they go into the hospital, they don't say, wow, you're on too many meds, let's take you off some of these. They generally add on more medications which seems to be pretty typical there. So again, what are the consequences of this? Well, they're going to be more likely to have adverse drug reactions, almost guaranteed, even if they don't know they're having one. We can see a lot of things like hypotension, sedation, dizziness, falls leading to fractures. Things like that can be quite common. And then just decreased compliance because it's almost impossible to keep up with it, or they may not have the financial resources in order to be compliant, to actually buy the meds in the first place. So other reasons why we can see decreased compliance could be related to the dosing schedule, as I mentioned, the economics of it, or they may have lack of support that can keep them accountable, make sure they're taking their medications like they're supposed to. Some people have mental decline that keeps it so they can't remember the right drug or time. I can't tell you how many, during my fellowship, when I did that 2-year fellowship in the Poison Center, part of my staffing responsibilities was manning the phones at the Poison Center on every third weekend, basically. And I can't tell you how many times I get calls, usually about 8 or 9 o'clock in the morning, elderly patient call up and they say, oh, I was taking my Spiriva, which is tiotropium, which is a COPD medication. It comes in a little capsule that you place into the inhaler, and then you press a button that pierces it, and then you can breathe in the medication. Well, that little capsule looks just like all their other capsules, and so I had so many phone calls of elderly patients saying, oh, I accidentally swallowed my Spiriva. What's going to happen to me? Do I need to go to the hospital? No, you don't need to, but it's one of those things where it was a common non-compliance because they're just, it looked like everything else they take. So visual impairment can be a big one. So having, and especially those, the labeling on those pill bottles is quite small. So that can be a challenge for a lot of them. I had one lady who was couldn't see more than 6 inches in front of her face, and she had a very complicated picture system on her medication lids where she had the red square was her metoprolol and the blue circle was her simvastatin. And I quizzed her on it just because I couldn't believe that she had this many meds and she was able to keep them all straight. And sure enough, she knew it all. Right? She was blind as a bat, but she could at least had a very good memory to keep things straight for her. Also, other things consider dysphagia if they're not able to swallow well. That may lead you to switching medication dosage forms. So, for instance, if someone with Parkinson's is not able to take their Sinemet anymore tablet, you may have to switch to a liquid formulation, for instance. IV access can be difficult for these patients. Either they're dehydrated or they have frequent IV access, and so they have a lot of scar tissue. It's difficult to achieve there. And just, is the patient willing to adhere to treatment? At a certain point, you may just get fed up with it and say, you know what, it's not really doing me a whole lot of good. I'm 80, 90 years old. I don't really care anymore. I'm good to go, right? That's when you kind of are thinking more so with end-of-life treatment, with more palliative treatment there. And so you're trying to more focus on not necessarily the quantity of life you can achieve for your patient, but the quality, right? So yeah, if someone is living to be 110, but they're miserable every single day, is that really worth it as compared to dealing with someone who, is perhaps younger, right? So those are all kind of value judgments that is going to be, very dependent on the patient there. Basically when we are dealing with those patients over 65, we have to start to kind of tailor that treatment plan as well in accordance with what their goals are. That's why you always have patients that have, a lot of them will have very specific DNR orders and things like that of what they do want and don't want in case they come into the ER. There's all kinds of things you'll see there. But this is a case here where we have, you can see that palliative treatment, you're more likely to do that as time goes on and trying to improve that quality of life. So for instance, when you have a lot of patients, and my wife did a lot of this in her second year of residency, which is when she specialized in palliative care, is a lot of this is just making them as comfortable as you can, right? You can't do anything for that lung cancer anymore, but we can at least make you comfortable until it's your time to pass, right? So that can be a really big thing to focus on them. And again, it's not just things like pain medications, but it's things like, can they have a good bowel movement? right? You don't realize how significantly your quality of life can be affected if you can't have a good bowel movement until it happens to you or happens to a family member. It can make really all the difference for them if you can get them like on a good bowel regimen, have a good bowel movement. They can feel so much better, right? Things like pain scores will come down, vital signs will will stabilize. It's pretty wild to see when you have patients that are like really that chronically constipated. But anyway, other things we expect to normally see as patients get older, you're going to see cardiac function start to decline. We're going to see renal function definitely start to go down. Remember, though, that when you're dealing with things like looking at creatinine clearances, that the elderly patient's creatinine may not tell the full story, especially as they get older and they have a lot less muscle mass. You see these patients that are like, 80, 90 pounds sopping wet. They're 90 years old and their creatinine's like 0.6 or something. And you say, wow, that looks really good. Your kidneys must be awesome. It's just they can't really produce the creatinine anymore in order to show you what their actual, what they actually can do in terms of being able to filter stuff out. And so you may try to hedge your bets a little bit. Usually, a little trick that I do, I won't put this on the test, but one thing I like to do, I haven't had to do this in a while since I've been doing peds, but if I have a patient like that who is very elderly, very kind of slim, doesn't have a lot of muscle mass, I'll oftentimes will just kind of bump, when I'm doing the calculation for their creatinine clearance, I'll bump up their creatinine to 1, just to make sure I'm not kind of being too aggressive and kind of overdoing it with like things like, antibiotics and whatnot. And then you can kind of readjust, based off of levels and things like that, Again, just a graph kind of showing you how you're seeing the eventual decline in most organ functions as time goes on and you get older. And most of you don't have to worry about this, but for some of us older folks, the Grim Reaper is right over our shoulder. We feel it every day, right? Just kidding. Anyway, from a GI standpoint, you can see some issues here in terms of not necessarily function so much, but we can see things like a lot of dietary interactions here. We can see things like, chronic constipation can be affecting the absorption of medications, and so overall, we're not going to see that really bioavailability of medication changes so much, but we may see some issues in terms of the rate of absorption might be slowed in some of these cases here. And also you want to look at the liver as part of the GI tract as well in terms of its ability to metabolize. As they're having liver dysfunction, either due to things like hep C or just chronic alcoholism or whatever, you may find that metabolism of the drugs is actually slowing down, and that can lead to higher levels, which can lead to some issues, as we know, right? In terms of absorption, as I mentioned, no huge changes, probably just, if anything, a slowed absorption, but it should still, have roughly the same levels. But again, the biggest changes are going to be things like increased use of OTC meds that can bind up and interact with other, other medications like laxatives and antacids. Looking at their dietary changes, or how much vitamin K are they consuming? Are they getting enough insoluble fiber, things like that? Or even disease states like diabetes, which can actually slow down gastric emptying due to gastroparesis there. But overall, things should mostly absorb pretty well. Now, drug distribution is important. I think someone asked a question about this yesterday, but you can see here how, generally speaking, you're going to find water content going down, and you will see fat content typically go up in a lot of cases here. So overall, lean body mass is going to be going down, but you're going to see more adipose tissue there. And so certainly that can affect distribution of your medications there, which can mean things like, if I'm giving a hydrophilic medication like gentamicin, it's not going to be able to distribute as far. So if I'm giving the same milligram per kilogram amount to an 80-year-old versus, say, a 30-year-old, I'm going to get very different levels. The concentrations are going to be much higher in that elderly patient than I would see in the younger patient, because it's all going to be more concentrated because there's less body water for it to distribute to, right? So you may have to see dose adjustments based off of age, or just based off of things like, their, how much lean muscle mass they have, etc. So you can see some alterations there. Other things that can affect distribution can be things like serum proteins. As those go down, things that have high protein binding are going to be more free to distribute out elsewhere, and so that can lead to sometimes side effects and things like that. So you want to think about high protein binding drugs like phenytoin or something is going to be more free and have a higher free fraction. It can affect things like the CNS and cause more sedation and cause more falls and whatnot, right? So you can certainly see that. And again, kind of just what I refer to there is that free fraction can possibly change. And so in some cases, we even have adjustments we can do based off of things like their serum albumin. We'll say, okay, if the albumin is this, and we can actually adjust to get an idea of what the free level of the drug looks like and adjust the dose based off of that. So sometimes we'll do that for phenytoin for patients who have hypoalbuminemia in some cases there. In terms of clearance, so we know things are going to be slowing down. Renal function just declines anyway with age, but some may have a more rapid decline than others. Certainly, we discussed a lot about chronic kidney disease in those patients there, which means we're going to see longer half-lives for many medications, and we're also going to see that they can have accumulation of metabolites of drugs, right? And, not every drug is just you metabolize it and then it's done, it doesn't work anymore. Some of them have active metabolites, and so that can be a bit of an issue, and we'll talk about some specific cases for that a little bit later on. This can also be affected by their hydration status. As I mentioned, a lot of times they get dehydrated, not enough water, and then that can cause an acute decline. So they have an acute on chronic kidney injury that leads to them having their medication levels go sky high in some cases. As you can see, I'm trying to be hydrated myself. So just to reiterate, and I'm not going to have you calculate this on the exam by any means, but just to show you sort of the factors that go into that, how things can affect your ability to calculate that creatinine clearance. Here's one example of the Cockcroft-Gault equation. Remember, the age is up here on the top, so as age goes up, this difference here is going to be smaller, so that automatically shows that the creatinine clearance is going to go down with age. So if you have someone who's 90, they're automatically going to have a lower creatinine clearance than someone who is 30. Just based off the fact that we know that, or at least this is what the model that told us, right? When we developed the model there, this is what told us that as age goes up, creatinine clearance goes down. They're inversely proportional, typically. You can factor in their weight there, which of course you always have to be careful, especially with those that are obese and adjusting that. But notice the serum creatinine is down here in the denominator. As this value goes up, creatinine clearance is going to go down. But recall, you can have patients who have less creatinine than what they should normally have. If you have amputations, if you have low muscle mass due to just maybe poor nutrition or things like that, it can give you a false sense of security in thinking their creatinine clearance is better than it is. And you have to consider that when you're looking at things like drug levels and whatnot. Now, again, typically we, for at least a Cockcroft-Gault, we multiply by 0.85 for women. That is generally because they have less muscle mass on a kilogram per kilogram amount than the men do. Again, this does not always hold up depending on the type of patient. So, but that's the model. It's kind of the way it is, and our way it was made based off of the patients that they had way back in the day. And it still works pretty well for the most part, right? So, again, not everyone fits that mold, but generally speaking, it does pretty well. But there are others that are out there. Some will take into account whether or not patients are black or not. Some will have different modifiers based off their age or serum creatinine. So, just be aware of what calculations you're using. Be aware of what some of the shortcomings of it could be when you're trying to evaluate your patient. Because you may get the number, but it doesn't match up with what's happened with the patient, then something's off. And you want to treat the patient, not the number, as we know, right? Other things we can see, so as I mentioned, drug clearance can be slowed down because either you're getting less blood flow through the liver or the liver function itself is starting to decline. And so, for instance, we can see things like first pass metabolism might be decreased. So you may see like lesser functioning of things like, phase 1 reactions like CYP450, for example. You may see changes in bioavailability because of that, but also just that decreased metabolism as less blood flows kind of circulating through. Think like CHF patients and things like that. So, a lot of times the question is like, well, are the patients like more sensitive? Are their pharmacodynamics really changing here? And it's not really that most of the time. Most of the time it's going to be more so the kinetics or what's changing. So that way, if I'm giving a 30-year-old a certain dose of a medication, they may have, standard effects from the drug, but I give it to a 90-year-old, if I'm giving on an equivalent dose based on their weight, you're going to see potentially the kinetics are leading to that drug to be have higher levels for that patient, which may lead them to be having more side effects and things like that. But also, you want to look at things like the homeostatic response is going to be lessened in these elderly patients. They just can't really respond as well as a younger patient can in terms of things like changes in blood pressure, changes in temperature, things like that. And so because of that, they may seem more sensitive. So if I give a young patient a beta blocker and they go from sitting to standing, they're probably, may feel a little dizzy, but they're probably not going to keel over, right? As opposed to the elderly patient, they may not be able to tolerate that at all. And that's where you see a lot of those falls and fractures that can happen there, right? So I'm going to kind of dive into some specific drug classes and some examples of ways we may want to adjust how we're using these medications, maybe adjust which medications we're going to use and things like that. So there is a list out there. It's called the Beers list. which is a bit of a misrepresentation of what it is, but I guess it was the Dr. Beers that came up with it. But it basically is a list of medications that you need to be really careful with, or maybe avoid in elderly patients. I could put that list up here, but it has everything on it, so it's not super useful from that standpoint. So I like to kind of go over just a few different drug classes that tend to be more problematic for elderly patients, and maybe some things we can do to get around that. So with sedative hypnotics, this includes things like your benzodiazepines, anything for sleep, antihistamines. All these things here can be really dangerous in elderly patients because, one, they can affect their mental status. They can worsen things like dementia. They can really be problematic, especially in cases where it can lead to things like dizziness and can lead to falls that happen here. And again, that can usually precede a lot of fractures. But not only that, but they also run into issues of things like accumulation of active metabolites. That's why benzos are super dangerous in elderly patients, because a lot of them have active metabolites. A lot of them have high lipophilicity, so they like to kind of build up storage in the adipose tissue. And so they stick around for a long time, and that can lead to a lot of this kind of prolonged sedation, more dizziness and falls and things like that. So if you recall, that's why I like the LOTT benzos, LOTT, stand for lorazepam, oxazepam, temazepam, and then triazolam. Those are the four that are really preferred in elderly patients because they're either more hydrophilic, they have shorter half-lives, or they don't undergo renal elimination. They don't have active metabolites, this would be another thing too. So the benefits there are that they're going to be able to be cleared easier and more quickly out of those patients, and they're not going to have the same propensity to build up and hold on to those levels there. So we like those better. If you can avoid using benzos in those patients, that's always preferred, but that may not be feasible based off of what you need to use it for. In terms of analgesics with opioids specifically, this can be really a big thing here because, yeah, the drugs will work for them, but you'll find, especially with more kind of progressive, pain sort of conditions and things like that, cancer and whatnot, they can build up a huge tolerance to the analgesic effects of the drug. So they can be on huge amounts of opioids, and you can have 90-year-old grandma who, again, is 100 pounds wet. They can handle doses of morphine that would knock out a horse, basically. And there's been cases of kids going into, or adolescents getting into grandma's medication, thinking, oh well, if grandma's taking it, can't be that bad. And they, go completely comatose practically from it. So they do build up a lot of tolerance to that. They still can be susceptible to those respiratory depressive effects, especially if they're going to be mixing and matching with other benzos. They're mixing it with things like alcohol, with muscle relaxants, which are, again, the common trifecta I would always see in the ER is people coming in on an opioid, muscle relaxant, and a benzo. That, and usually some alcohol too, and they would just come in basically either intubated or needing to be intubated because they're so sedate from all of those medications, just kind of adding on to one another there. But other problems you run into with opioids specifically is you can have buildup of active metabolites. So for instance, with morphine, there's a morphine 6-glucuronide that can build up and lead to additional respiratory depressant effects. Things like there used to be a drug called propoxyphene. I'm trying to think, is that the one I'm thinking of? Trying to remember, it was Darvocet, I believe it was propoxyphene. It's been off the market long enough now that I basically had forgot about it. But that was actually really bad because that would actually lead to a buildup of metabolite that would lead to things like seizures or cardiac dysrhythmias. We don't like to use meperidine in elderly patients because they will end up causing things like seizures that can happen there. Yeah, it was propoxyphene. I was getting that wrong. So hold on. You see the drug name there, propoxyphene. If I could spell it right, that'd be nice. Yeah, so that was taken off the market probably when I was in pharmacy school due to the fact that the elderly patients were developing all kinds of things like cardiac dysrhythmias related to that. Actually, it wasn't that good of a drug anyway. But yeah, so you have to be really careful with opioids in this older population too. In terms of things like antidepressants and antipsychotics, a lot of these are going to be either sedating, so you kind of run into the same problem as you did with the sedative hypnotics. You run into issues, especially with things like lithium, that if they have an acute decrease in kidney function, they're going to build up levels of that really quickly. They can lead to things like seizures. Luckily, nowadays, there are antidepressants. A lot of them are a lot safer nowadays than they used to be. So, excuse me, you're a lot better off using something like an SSRI as being safer, better side effect profile than something like a TCA would be. However, you're still see some people that have just been on it for decades and they just stay on the same medication, right? And so again, that can still lead to side effects as they kind of decline from a physical standpoint. From a cardiovascular standpoint, this is going to have a ton of issues here. Again, as you lose that sort of homeostatic sort of reserve, these drugs are going to have much more pronounced sort of effects here. So things like diuretics, things like your calcium channel blockers, beta blockers can all lead to issues in terms of things like orthostatic hypotension. This tends to be a little bit better with things like ACE inhibitors and ARBs. They tend to be less likely to cause problems with this. But, remember, too, if they have something like BPH and they're on something like, doxazosine plus their antihypertensives, you're going to see a lot of synergy there and more likelihood to run into things like dizziness and falls and whatnot. Someone asked, can I repeat, which benzos are best? Bears beats Battlestar Galactica, right? So it's going to be LOTT. I guess I could put up my own sticky note. I don't even know how to do that, actually. Oh, no, the wrong one. How do I put up a sticky note? It would help if I even know how to use my own software here. But anyway, so it's LOTT, so it's going to be lorazepam, it's going to be oxazepam, temazepam, and then triazolam. Those are the 4 good benzos, I should say, for elderly patients. So those are the ones that we like there. I just provide you guys the board. I don't have to actually know how to use it, right? Anyway, so also you can see a lot of things like electrolyte imbalances, more so with your diuretics, right? Especially loop diuretics can be much more likely to cause hypokalemia, hypomagnesemia, things like that, which can then feed into arrhythmias, right? So especially if they're on antiarrhythmics, you can find that they will have issues in terms of either they're holding onto the drugs for longer, they're having more poor hemodynamic reserve. So again, if they do have any sort of transient arrhythmia, they can't really respond to that as well. So their blood pressure can tank real quick. And again, those electrolyte imbalances just kind of make the heart sort of a ticking time bomb, so to speak, and increasing that likelihood of arrhythmias. Things like lidocaine, its clearance goes down pretty significantly. In elderly patients, we have to sometimes even like half the dose that we're normally using if we're using that for antiarrhythmic purposes. So it can be pretty difficult from that standpoint. And again, remember, if you have someone seeing their psychologist and their psychiatrist, they're seeing a person for their ortho concerns, they're seeing someone for their previous MI they had, they're seeing someone else for. Everyone's prescribing all these medications. They're not necessarily doing their due diligence and looking at the full list to see if there are going to be any problems here. What sort of interactions can I expect? And you may be that central person. You may be that person working in family practice or internal med that is, seeing this patient, doing kind of the whole view and saying, wow, there's some weird things that are on this list here. And again, the tendency is for people to not make any changes to other people's work. But while that is a professional courtesy, I would recommend at least calling someone up on the phone and saying, hey, I'm noticing at this patient here, I'm noticing X, Y, and Z. It's interacting with this is prescribed by someone else. What do you think about that? Do you want to do anything about it, etc.? Again, if you know the patient's having a problem with it, they're more likely to want to change it than if, it's just a theoretical thing. So at least, see how the patient's doing with what they got already. And again, as the number of meds is going to go up, it's almost going to be 100% chance they're going to end up developing some sort of adverse reaction. Mix into that as well if they're taking OTC and herbal medications. You're just getting a very complicated sort of picture. And again, they're going to experience something, right? They may not know that they're experiencing it, or they may not associate what they're experiencing with their medications, but it's there. And so you might be the one person that can sort of identify that. Just like I mentioned, we had a family member that called us up. Those things like, wow, I'm having all these stomach cramps, and I need like an antispasmodic. I need like a Bentyl or something like that. Is there anything over the counter they can get to help out with these stomach cramps that I'm having? And we're just like, okay, well, what else is going on? And when's the last time you've had a bowel movement? And they're like, oh, it was like last week. They were like, last week, the last time you had a bowel movement. And so we're trying to inquire more. And we're just saying like, well, are you normally constipated? And she's like, well, yeah, I guess I am. Yeah, it normally comes out, little rabbit pellets basically coming out. And we're just like, oh, like that's why you're having the abdominal cramping. It's because you're so stopped up because of the fact they're on pain medications and a calcium channel blocker and all these various things that are leading to the constipation. But again, they may not be able to put that 2 and 2 together. So you got to be the smart person to be able to recognize that. So instead of adding on a drug from the cramping standpoint, really what you need was some heavy duty laxatives. And then all of a sudden, guess what? Have a bowel movement, feels so much better. It's weird. But anyway, so, as we're seeing here in terms of reasons why patients are having drug reactions, it could just be the number of meds that they're on. It could also be issues in terms of, again, prescribers not taking into account things like age-related changes that occur. renal function, liver function, etc. Patients can certainly be non-compliant for a whole host of reasons, things like either intelligent non-compliance, or they're deciding not to take it on purpose, or because they don't like the side effects, or if they're taking it inappropriately because they misunderstood directions or things like that. And of course, seeing the multiple providers. Richard saying, Florida Blue would have a pharmacist call and counsel me once a year on my patient's medications. We would go through the list and discuss, and I could bring up things when we go to the PCM. That's fantastic. And I know, I think over at the College of Pharmacy at UF here in Lake Nona, they also have a counseling thing where they'll actually call up patients. It's called medication therapy management, or MTM. And so that's a big role that pharmacists have started to fulfill in the past, couple decade or so. And so that's a big role they're moving into. So it's nice because, while we can't make the changes ourselves, we can at least come up with ideas or suggestions or questions to the providers that they can then take back to them. And so, because again, if you think about the role of a pharmacist, like in the retail setting, it's like, in some cases it can be largely automated, right? It doesn't take that much, skill to be able to count to 30 by fives and, use a butter knife to put it into a pill container. But it's all that knowledge we have in terms of like medication management that is important. So that's why you see kind of programs like that, which is fantastic. It's really good from a patient satisfaction standpoint. They have someone they can talk to, Anyway, I mentioned the BC powders and goodies thing already. So just in ideas of questions to ask these patients, because again, you always want to start off when interviewing patients going from open-ended questions down to more specific closed-ended questions, because you'll find you get a whole lot more information when you allow the patient to speak. But if you ask them a question they can just answer a yes or no to, then you don't really get a whole lot out of them. You'll be surprised by how much patients will divulge to you when you're asking these open-ended questions. Sometimes way too much, and you have to kind of redirect them a bit to actually answer the question that you ask them. But that is generally the way to do things. So again, when you're asking about their medications, oftentimes you can ask them, like, hey, are you taking this like I told you to? And frequently they're just going to say yes, because they don't want to get that disappointed look from you, or they don't want to disappoint the provider. And so what you can rather do is just ask, hey, how do you take this medication? What do you do? And have them describe it to you to see if it matches up with what they're supposed to do. Or you can ask, hey, if you miss a dose, what do you do? And they may say, well, I never miss doses. But if you did, what would you do, right? So they may not be doing things appropriately, like, they may be doubling up on their warfarin, for instance, which may not be always appropriate, or doubling up on their blood pressure medication. So, you want to find out what is their thought process for this stuff, because what may be obvious and intuitive to you is nowhere near to what the patient is thinking in a lot of cases there. Asking about medications they're taking that are not on the list is important. Asking about things like non-prescription drugs. Again, a lot of times you're going to find that they're using, especially like in Florida now that we have medical marijuana, that's not something that would come up, for instance, on their E4s, right? Because it's not actually an FDA-approved product they're getting from a pharmacist. They're going to a dispensary to get the medical marijuana, and it's not something that shows up on their medication list always, right? And again, you have to ask about things like, well, are they trying like CBD oil? Like, I know my mom has a lot of chronic medical conditions, including pain, and she's trying out some CBD, and her physician had recommended it for her, right? But it's one of those things where it's like, okay, well, how could that be interacting with our other medications? Going through the list can be kind of challenging there, but if you don't ask about it, then the patient's never going to tell you, right? Asking about things like, homeopathic meds as well. Oftentimes they're not going to have a huge impact on things, because most of the time those are so dilute, they're basically getting no drug whatsoever. But certainly herbals can be playing a role. What vitamins are they getting? They could be interacting potentially. You're asking about medications that belong to other people. This may be a tough one to get patients to open up about, simply because, again, that probably sounds like they're doing something wrong or bad, and so they don't want to cop to it. But, they could be certainly doing that. So if, Ethel has, some Cipro left over from the last time she had a UTI, and then all of a sudden, you start to feel like you have one coming on, you might borrow her Cipro, right, to avoid having to go see the provider potentially. They get medications online or from other countries, which may sound silly, but, things may be a lot cheaper or more available outside of the country they may be ordering from, or online, or things like that. They typically will hold on to medications even if they've been discontinued. So ask about, things that they are not really prescribed anymore, if they're still taking them or not. And then checking things like expiration dates. I will tell you, expiration dates are generally going to be based off of the legal requirements. So for instance, if you get, say, a 30 count of metoprolol from the pharmacist, that expiration date is going to be basically the year that prescription is good for. So if you wrote for this on today, that prescription is no good in 1 year, right? That's when all non-controlled prescriptions expires in 1 year. That metoprolol might have an expiration that's several years after that, but the patient's not going to be able to know that. And generally speaking, you're going to find that medications stay good for a lot longer than what their actual thing on the bottle says. But we still tell them don't take expired meds, but secretly it's like you probably could. There are certainly exceptions to that, right? So don't take that as carte blanche to do that for everything. But basically, things that are like protein based, things that have to be refrigerated, medications that have to be reconstituted, like antibiotics, those do have legit expiration dates and should be adhered to. So for instance, they had some amoxil that they had mixed up that was from a year ago. That amoxil no longer is any good, right? That liquid amoxil versus the tablets, which may be good for years potentially. There was an interesting study that was done in a pharmacy journal where there was an older gentleman who was a pharmacist for like forever, and he had this very old-timey pharmacy, and he had medications from like back in the 30s, and they actually went through after he passed away. They were cleaning out the place, and they found all these old meds, and they went through to test them to see did they actually have the same amount of drug that they said was supposed to be in them, or had they degraded, because they want to see our expiration date's really truly a thing. Interestingly enough, they found that almost all of them were either at the same amount that they were supposed to be back in the 30s or whenever it was. Some of them actually had more drug than they were supposed to, maybe due to like bad manufacturing practices. The only thing that was really degraded was aspirin. Aspirin itself tends to be really not that stable. And so that was one of the things that was kind of something that may have more credence to the actual expiration dates on there. It's kind of interesting. So, again, asking about things like, Shelby, you don't have to humor me. I know that's not that cool. I'm just kidding. Are they taking medications independently? If not, like who's helping them out? They may have family members or caregivers that can help out with that. What kind of dosage form systems are they using? So do they have a reminder system that helps keep them on track? I'm sure most of you probably seen some of the pill minders like this. I honestly hate these things because from a tox standpoint, whenever you have little kids go over to grandma or grandpa's house, they will oftentimes those grandparents' house are not child-proofed, including these things will be left around, and they'll go in and they'll grab like Tuesday evening and Thursday afternoon, and they'll just chow down whatever's in there. They'll say, well, what was in those boxes? And the patient will be like, I'm not really sure. Someone else does this for me, so I'm not sure what is actually in that box. I just know I take the box when it says to take it. So now all of a sudden we have like an unknown ingestion for a kid, which can be a bit of a challenge. So, but these are good from a reminder standpoint for the patient. Some patients, I'm sure you did, Jackson. Yeah, it can be unfortunate, especially when they're on much like heart meds and blood thinners and things like that. It can be pretty unfortunate. But anyway, do they have any kind of like pill reminder system, that can help them out? Most people have some sort of, device that can help. You can set an Alexa up to do that, and at least you can talk to. But technology may be a challenge for some of these patients here. I know I think someone on our staff still uses a flip phone, which I find very funny. We always make fun of them for that, but it just depends on what kind of technology they have access to, and it can help them out with that sort of stuff. If medications require technique to administer, so things like inhalers, how are they using those inhalers? Because they could be using it completely incorrectly, and you wonder why their asthma is not that well controlled. Well, it's because they're not using the inhaler correctly. Are they utilizing anything that's injectable, but maybe their hands aren't really as dexterous as they once were, and they're not able to really give themselves those injections very effectively? Those are things you can ask about as time goes on to see, okay, well, how are they taking these meds? Is it effective? What kind of things can we do to try to, shape things up a little bit and become, kind of maximize their, their medication therapy? Overall, too, remember that in terms of compliance, patients will lie to you just because they don't want to get, the disappointing look from you in a lot of cases, whether that would actually happen or not. But, so always try to have an open, curious sort of environment to ask questions. That way they're not going to feel like they're going to get, yelled at for not taking their meds like they're supposed to. But remember too, like medication expenses are very important to try to keep down. Most of these patients are on a fixed income, and so while you may have a nice dinner that was paid for by a drug company that says, wow, this new NSAID is amazing, you should give it to all your patients, but it costs a whole bunch, and their insurance doesn't cover it, then they're probably not going to take it, right? Whereas you can get something like aspirin or ibuprofen relatively cheap over the counter. So you think about the economics for your patients. We deal with a lot of A lot of poor patients in Florida, especially in the rural areas, and so this is extremely important for them to make those decisions like, am I going to eat or am I going to get my medications? So you want to make it as cheap as you can for them. Remember that try to keep things simple. So if you can use combo drugs, that's helpful. If you can use fewer drugs, or if you can try to schedule things where they can take more of them at the same time, that can be useful. And always consider that intelligent non-compliance. If they're having a side effect from a drug or they think the drug's not working, they may just stop taking it, right? Like, well, I don't feel like I have hypertension, so why am I going to take my ACE inhibitor? Well, because you can't feel that until it's way too late. And so you want to keep them, understanding why they should be taking this, why it's important to do what you're telling them to do, right? And the reasons for that. And again, just assessing they even physically take the drug like they're supposed to. Can they swallow it? Can they inject it? Can they inhale it? Whatever the case may be, and try to find ways to try to help out from that standpoint. Anyway, that's it for the geriatric section. I think I'm going to cut it there for today, just because I don't want to start a whole new topic and then have to cut it off in a couple of minutes here. So any questions from you guys? Someone's asking, am I a fan of GoodRx for patients? I don't have a ton of interactions with that. I know some people can get some decent deals there, but yeah, if it's able to get them cheaper medications, I say go for it, for sure. If you can give them generic varieties, that's always helpful. Just have to be shown to be bioequivalent, so that's always going to be a big benefit too if you can. What other questions do you all have? If not, I release thee. You may flee from this live stream, and I will see you again. Fall back into my clutches. What is it, tomorrow? Same time, 12:30. So we'll talk about ER stuff. We'll get into intubation. We'll talk about paralytics. It'll leave you speechless and breathless because you'll be paralyzed. But yeah, we'll go from there. So thank you. Have a great day, and I'll see you all tomorrow.